Hi, I'm Lois Beres at KZGN-TV, and this is Ridgecrest Talk. Today I have another one of the good guys from Ridgecrest. I have Celia Mills, who is the Director of Nursing at Ridgecrest Regional Hospital. I almost said community. Way back when I was on the hospital board, it was community hospital. She's going to be talking to us about some of the neat things that they're doing at the hospital, and also cover a little bit about how Ridgecrest is prepared if something were to happen, Ebola, in our valley. So, welcome.
Thank you.
Thank you for coming. I appreciate it. And you've been with the hospital for how long?
It'll be 26 years on November the 14th.
Okay, not a newbie. She's been there a while.
Yeah.
So I guess you've seen a lot of growth and change. And
yes, I have, because when I started, it was Ridgecrest Community Hospital,
so you were still there then.
So we've seen, you know, the building of the outpatient pavilion, the building of the tower, and we've seen the start of the rural health clinics, the expansion. There's a lot of great things that have happened in the 26 years that I've worked there.
There really is. Mm-hmm. There's so many things, services that we have now that weren't even on the drawing board.
Exactly.
When that started back then. One of the things that is on everybody's mind right now is Ebola. And the hospital, I imagine, has had meetings and talked about it and done all that. What are the preparations? What are we doing for that?
So we have a team which is working on our Ebola preparedness plan. Immediately we realized there was a concern for potential cases, which is very, very slight at this time. We wanted to make sure that our frontline staff would be able to identify a person who might be infected with Ebola. And you need to remember that this is going to be the rare situation. There are very specific things that we look for. If somebody presents to any of our clinics, the emergency room or the urgent care with a fever, they're going to be asked if they've traveled outside of the United States.
Okay.
And if they say yes, we're going to ask them where, and if they say West Africa, then we have a protocol in place to immediately isolate the patient and take care of the patient, take care of the staff. We have all the necessary personal protective equipment to wear to protect the staff, and so we can take care of this person until it's decided whether they are at risk for the disease or not. You know, people have seen on the news all the people in the bubble suits that we see in Atlanta and places like that, but really
look like space people.
They do. Yes. And really the precautions that we need to take are ones that we take every day for other different infectious illnesses.
That's remarkable, because it's something that you're used to doing anyway.
We are, but what we need to do is we need to make sure we have a plan. We need to make sure that our staff are educated, and we're in the process of doing that, so that they're comfortable with the procedures. So if we should have to use it, we're ready to do it. It'll be second nature, and the patient will be well taken care of, the staff will be protected, and we'll do what we need to do.
Oh, that's great.
So, you know, and there's a lot of concern about Ebola and whether, you know, how easy it is to catch. And there are several things to remember. The first thing is that until you show symptoms, and research has shown this, you cannot catch Ebola.
Okay, so if I were to walk up to somebody who may be in the process of incubating it or something, and they don't have symptoms, I'm not going to catch it.
And those symptoms, to begin with, are a fever, headache, joint pains, nausea and vomiting, you know, and as the disease progresses, you might have unexplained hemorrhaging or some diarrhea. But in the early stages, no, unless you're showing symptoms, you cannot catch it. And then you have to have close physical contact with the person and really their body fluids. So, and the way the virus enters the body is either through a break in your skin or through your mucous membrane. So we're talking about eyes, nose, and mouth. So that's why you see people with the goggles, the face shields, the masks on, and gloves, and the gowns to protect them from catching this. You can't get it from breathing the same air. It is not airborne. The CDC today released some sort of a compilation of all the research that's been done on the spread of Ebola, and it categorically states that it's not an airborne disease.
Well, that's good to know, because I've heard both sides.
Yes.
On that same news, probably.
Exactly. And the CDC has a wonderful website. You can go to cdc.gov.
Okay.
And when you go to that page, immediately you'll see Ebola outbreak. You can click on there, and there's lots of information for people And the thing we need to remember is that in the United States, there have been 2 instances of transmission or spread of the disease within the United States. And both of those, unfortunately, were 2 healthcare workers. But they were in very close contact with the patient, and especially towards the end of the illness when you have much more of a chance
and
because
he's
there's
more
no virus.
infectious.
Yes, there's
Right.
much more virus in his body at that point. So our risk is minimal. You know, we're much more likely to get the flu, something like that. So
how do you guys there differentiate between the flu and Ebola? How would you know?
well, and you see, this is the big thing. Flu presents with a fever, body
Very
aches,
similar,
headaches, sometimes
right.
you're nauseated or vomiting. The difference will be, have you traveled to West Africa?
There you go. Okay.
Have you been in contact with a person with Ebola or suspected Ebola? That is the question. So
That's
if
the major one.
If it is no to that, then you're going to
Treat
be
for the flu.
For flu.
Okay.
And we also have to remember that people traveling from West Africa may present with symptoms, but it's not Ebola. It could be malaria or typhoid, and that would be part of the workup too, because those diseases present similarly
And
as
those
well.
are infectious too, are they not?
From the West African countries, yes, but
Okay.
you present in a similar manner before it's ruled out.
I see.
And should, in the highly unlikely event we have somebody present with suspected Ebola, we have to call the Kern County Public Health Department. They will be with us every step of the way. The CDC has teams set up to come to anywhere that has a suspected case and help that institution look after
Oh, I
the
did
patients.
not know that.
Yes.
So you would call Kern County, they would call CDC, and
Yeah.
then you'd be converged
Yes.
upon with people that are
Yes, would be
knowledgeable.
experts. They would be guiding the treatment. They would be making sure we were doing the right procedures in caring for the patients. So the utmost care will be taken to make sure that the patient gets the right treatment and that the people who are caring for the patient are
And you
properly
have
protected.
capacity over there to isolate that
Yes.
patient right away.
We do. We do.
Okay.
We have a specific room set aside in the emergency department, and then should we need to move the patient within the hospital, we have another room set up for that as well.
Great. Well, we're just about getting ready to go to break, so we're going to come back and talk about some more things that they do at the hospital that maybe you're not aware of. And Celia's being director of nursing has heard of all of it, knows all about it. So we're going to talk to her in a bit. We'll be back in a couple minutes. And you're back. We are back with Celia and Lois. Celia's Director of Nursing at Ridgecrest Regional Hospital. And they have done so many new things since she's been here. You told me you've been here with the hospital for how many years?
26 in November.
26 years.
Yeah.
So she's seen it really grow from a very small community hospital to the regional hospital that is today, with the pavilion and the skilled nursing and some of the other things that has evolved into. And you can tell by her accent that she's not from Ridgecrest. Where are you originally from?
I was born in London.
Oh, okay.
And I grew up near Liverpool, and my husband was in the English Royal Air Force, and we came for a weapons trial in 1988.
I probably knew you. We were here at active duty at that time.
Probably,
so
yeah.
Very interesting.
And we loved it so much we stayed. And one of the
Great.
reasons that we stayed was that I really enjoyed working at the hospital, and I loved my job.
And your husband is working here too now?
Yes,
or?
yes, he's working with the DOD.
That's
But
great.
we love Ridgecrest. It's a great place to be.
It is a good place to be, and I'm so proud of our hospital, because being in this secret city, they don't always, small places like this don't always have the facility that you guys have. So the next thing that we wanted to talk about is the fact that the hospital has now taken over what used to be, Ridgecrest Manor or something?
Ridgecrest Healthcare.
Yes. Ridgecrest Healthcare. Tell us a little bit what you're doing with that.
Well, Ridgecrest Healthcare, as probably most of you know, is a skilled nursing facility. It's basically for older people who can't live alone and need some level of care, not as critical as in the hospital, but they really can't live on their own. And so we have a wonderful administrator over there, Michelle Lemke, and a wonderful director of nursing, Sharon Aleo, and they have made great improvements in the facility itself, in the care that the patients receive. They have really made a great change in procedures that are done, and the residents are all very, very happy, and their families are very happy, and the community needs an excellent skilled nursing facility. We have an aging population, and those of you who have older parents, it's difficult, especially when you think that you might not be able to help them stay at home and be independent. It's wonderful to have a facility that you know and trust and can take care of our elderly population in a manner that they really require and deserve.
Because I have been over there, not recently, and it was almost a sad atmosphere. But you're saying now that it's perked up and things are much better.
Yes. The change, they've improved so much. It's wonderful to see, and the people who work there and the residents who live there really, are benefiting. And it's really interesting because we call them residents because it is their home.
That's true.
And so we're creating a great home-like atmosphere. They have activities. They get their hair done. There are trips. They really do. And the staff become more than just staff. They have relationships with the residents and their families. And when you have a great nursing home, it's a wonderful thing for a community.
It absolutely is. And for the patient or the resident, however you probably call them residents as opposed to patients. That is remarkable. My husband worked in a home like that way long years ago before he went to college, and he enjoyed it so much, and he still, up until his death, he was communicating with some of the families because they become family.
They do.
And now that is part of the hospital.
Yes.
So you are not the nurse in charge of that.
No, that's a big job, and I admire both Michelle and Sharon because they have a tough job and they're doing a great job. But they can take up to 99 patients when they're full, and so you really need a person who is experienced in looking after people in the long-term care situation, and Sharon is that, and she's a wonderful resource, and she is doing a great job along with Michelle.
How many people work over there? Do you have any idea? Because they've got to be around the clock.
Yes, they are. They're staffed 24/7 with licensed nurses. I don't honestly know how many employees we gained, but I know it was a lot, and our HR department was very busy getting everybody settled. So yes.
Well, that's great, and it's so good for the residents to be able to have a friendlier atmosphere.
Yes.
It was sort of just maintenance. The time I was over there once before.
I think that our elderly population is such a wonderful asset to the community. They've got so much they can teach us, and we can learn a lot from them. And I've always said it in my nursing career, I have a little soft spot for the grumpy old man. They're my favorite patients or residents, and you learn so much, and they have so much life experience that you can
It is
learn
remarkable
from.
when you can talk to them and they can tell you all the stories that you've never even heard about before, that you've heard maybe a little bit, and then they can personalize it for you. It's remarkable, and it's good for them too, because somebody wants to hear their story.
Exactly.
Which is excellent. So, and then you've got the pavilion, which is that just like doctor's office, or what is involved in that?
On the top floor we have doctor's offices. So we have Dr. Dussault, our gastroenterologist, up there. We also have the Drs. Lewis. So we have Dr. Chris Lewis is a surgeon, Dr. Layla Lewis is OBGYN.
I saw there in the paper.
Dr. Miller also has an office up there too, and also Dr. Monkar, he's a cardiologist who comes up from Cedars-Sinai a couple of days a week too. But on the lower level, that's where we have our outpatient pavilion. That's where we have the day cases. So if you need some antibiotics through your vein for a certain period of time, you can come in and have that done every day. If you've got a wound that needs some care, your doctor can arrange for you to go there. If you're going to have a day surgery, for example, a colonoscopy, or if you need your cataracts taken care of. There are quite a few surgeries now that used to spend a few days in the hospital that are now done outpatient. So laparoscopic procedures, minimally invasive, and you're up and about soon after and you can go home that day.
Last Monday, my daughter had, not here, but she had a gallbladder problem.
Yes.
And it was an outpatient.
Yeah.
I was amazed.
Oh, yes.
And you can do that now.
Yes, when I started in nursing, you're in the hospital for 10 days.
At
and
least.
Now you don't even spend a day, and it's wonderful.
And the next day she was up, walking about and doing whatever.
Yeah.
And it's just amazing to me what all you guys have done and what technology has added to your availability and that sort of thing.
Yes, it's a wonderful facility, and the staff are amazing too.
Oh, yeah. Well, the staff over there is just something really to brag about. We're so proud of everybody that works over there because they're upbeat and happy, and it's not a dreary place to walk to. So.
You know, you can have all the best technology in the world, but if you don't have an excellent staff, which we do have, you don't have a great facility. The heart of the facility is in the staff, and everybody who works there, whether they're a nurse or whether they are working in a billing office or if they're with our environmental services department, are all there for the patient. We're patient-centered.
Okay, and we're going to talk about this when we get back. We're going to go to a break, and we'll be back in about 2 minutes. Okay. We are back, and you're back with Lois and Celia, and we're talking about the Ridgecrest Regional Hospital and some of the services that they have now that were not available. And one of the things, or two of them, are home health and hospice. And those were unheard of 15 years ago, and they've grown and grown until now they have their own total staff, right?
Yes.
Tell me a little bit about what they do with those.
So there are two distinct programs. Home health is really part of the transition from being in the hospital to going home, but if you need a little extra help, perhaps you need a nurse to come and make sure you're taking your medications correctly, or you have a wound that you might need to learn how to take care of. If you need intravenous antibiotics, we can teach you how to do that.
Really?
Yes, it's amazing what you can do now. And then also, we can also provide rehab in the home, so if you need physical therapy, occupational therapy, or speech therapy.
And home health would go to the home and teach them?
Yes.
Wow.
Yes, and we also have nurses' aides who can help you bathe. Really, the stipulation for a home health is that you be homebound, and homebound really is that it's difficult for you to get out of the house. There are specific criteria that you have to meet, and Medicare and the insurance companies are pretty strict about it, but it's a great way of bridging the gap from hospital to home and making sure that you get all the care you need and then you don't get sick and have to come back into the hospital. And home health's been around for quite some time, but it's really grown with all these procedures that we find that people are leaving the hospital more quickly.
Well, like we were saying earlier, some things that used to be in the hospital for 10 days is now an outpatient situation. And so then the home health people might go to the home and help them.
Yes, and make sure they're recovering and do a wound check or something like that.
I see.
And then hospice. Hospice is something that is really dedicated for people who are nearing the end of their life. And the goal of hospice is for the patient and their family to be able to stay at home and be cared for at home and be comfortable and have a plan for what they want to do. And most times, in order to be on hospice, your physician needs to say that he expects that your life expectancy is less than 6 months. Now, it'll vary, but the hospice nurses are wonderful. They have a great way of making people comfortable, helping the family talk about difficult things. There's a social worker who can help with that. There's a hospice physician who's involved. There are volunteers. There's the ability for respite care. So if the family's taking care of somebody at home 24/7 and they need to maybe take a break, then the patient can come into the skilled nursing facility or our transitional care and rehabilitation unit for 5 days to give the family a break. They have many, many resources. They have great ways of using medication to make people more comfortable, less anxious. And a long time ago, I worked in hospice, and it was one of the most rewarding jobs. It's difficult when people that you know and love are dying, but if you can help the family and the patient.
That's one of the things that is a priority, isn't it, is helping the family as well as the patient.
Yes, and then there are services after the fact. For up to a year, they offer bereavement services and counseling as well. It's a wonderful, wonderful program, and we're very lucky to have it in our valley.
It's a good program.
Yeah, it is.
Yes, it is. And it's not morbid. They do it on an upbeat, positive way. And it's something that you probably, from what I've been told, should not wait till the last month or something.
No.
It should be something that is beginning, when, like you said, within maybe 6 months.
Yes, yes. The sooner that hospice can come in, the better the quality of life, the more time there is to get things sorted out and then have quality time in those last few months and be pain-free or have your pain managed and be comfortable. So yes, hospice takes patients at any stage, but it is really best if you get set up early.
And they can do things like help you bathe and that sort of thing that your family might not be able to handle or not know how to
And they're on
handle.
call 24/7, so if somebody's anxious about something in the middle of the night, they can call, and there's a nurse always available, and they can come out if necessary. So you have a lifeline, you have support.
Well, that's remarkable. That's something that I don't think we had for a while, or I didn't know that we had, is what I guess I should say.
No, hospice is relatively new. So
and it's so positive for the people that take part in it. So, and then we've got what, B-Wing has maternity or
yes,
something?
B-Wing is our maternal child unit, and we have a new director. Her name is Agnes, and she comes from Bakersfield with a wealth of experience. And so they're really working on some great initiatives. And one of the initiatives is that we are hoping that women will not be asking their physicians to either have a C-section or be induced before 39 weeks, because current research shows that babies are best if they're left inside as long as possible. And we used to think of 37 weeks. 37 weeks, as long as are good, you can have your baby. Not anymore. The babies born between 37 and 39 weeks can still have problems transitioning into life and might need to be transferred to a neonatal intensive care unit or
you don't have that here.
No, we have an agreement with Loma Linda, and we fly all our babies there. They're excellent, but we'd rather not do that.
Correct.
And there's a lot of research that shows that 39 weeks is best. The March of Dimes has a huge ad campaign about, staying pregnant until 39 weeks. Now, of course, if it's medically necessary, then that's a different question. But if it's elective, meaning you're choosing to do it, 39 weeks is best.
But you've got the ability, if a child is born early, that you could keep them viable and healthy until the plane could get there.
Yes, we have a neonatal stabilization unit. All of our nurses who work there can take care of children and infants in that situation. Our pediatricians help. We have Loma Linda who can direct the care. They'll send their neonatal team out to pick up the baby and transport it back.
That's just great. I mean, it's so exciting. Have we missed anything that is new or different or exciting that I haven't talked with you about?
There's so much at the hospital. We have an excellent radiology department. We have cardiac rehab. We have the transitional care and rehabilitation unit, which is a little bit of a step above a SNF for more acute cases where if you've broken a hip and you need some extra physical therapy to get you back on your feet, we have that. We do total joint replacements now with our with Dr. Desai, our orthopedic surgeon.
It's just remarkable what all has happened over there and what has taken part. And I thank you so much for coming and telling me all of this, because a lot of people don't realize what we've got. We have a gem over there, people, and it's something that we need to take advantage of. Thank you so much for being with me. And we'll have to have you back another time and talk about some more things.
I'd love to. Thank you very much.
Okay, thank you for coming. And we'll be back next week.